It's a very select audience today. In the next 40 or 45 minutes, we'll go through this conundrum of obesity and chronic kidney disease. The talk will be structured around looking at the magnitude of obesity and a little bit of a glimpse about the mechanisms and how does the other epidemic or the pandemic of chronic kidney disease interact with obesity, and especially in stages of dialysis, wherein you have this obesity paradox that patients who are obese actually do better when they are on dialysis. And then once they are to be listed for a transplant, which is the definitive treatment for chronic kidney disease, end-stage kidney disease, then they again face a lot of difficulties because there are a lot of these factors that cause morbidity in obese patients. So we'll go through this in the next 45 minutes, and I'm more than happy if you interrupt me to ask any questions or make any comments. Just before we start, this is a recap of what all of us know, which is the category of the weight or the body mass index. The normal weight is around 20 to 25. You can take it a little less and up to 18.5 body mass index as being normal. Certainly overweight, like yours faithfully here, between 25 to 30. Then obesity class 1, 2, 3. And the ones above 35 are called severely obese. And then above 40, BMI is classified as morbid obesity. What has been happening in the last few years is worldwide and in Australia, the prevalence of obesity is increasing. You can see in the last 5 years that the obesity, for example, in Western Australia in 2014-15, it was around 60% or little less than 60%, and now it has gone up to more than 65%. And every state has documented this overweight/obesity. So not all of these people are obese, but many of them would be overweight. But you can see the trend of how the overweight population or the obese population is increasing in Australia. A lot of new molecules have been described contributing to this energy balance and contributing to obesity. Ghrelin is a ligand that was discovered in the 90s in rats and is an appetite stimulant, and it is the one that causes your stomach to growl, or the hunger hormone. And then there are many counterbalancing hormones like the GLP-1 or the glucagon-like protein 1, the peptide tyrosine, pancreatic polypeptide, cholecystokinin, all these other substances that are downstream, they give a sense of satiety, stimulus to stop eating, whereas ghrelin is the one that stimulates appetite and makes people eat. And leptin in the longer run also suppresses appetite. So ghrelin was discovered in 1999 from the fundus of the rat's stomach, and it binds with the growth hormone secreting secretagogue receptor, and that stimulates the growth hormone production, appetite, food intake. And very interestingly, it also protects against some of the events in myocardial infarction, in patients who are in congestive heart failure, etc. We'll come to that a bit later. Adiponectin, low adiponectin is a bad thing. The adiponectin will prevent the angiogenesis, it will improve the insulin sensitivity, etc. But obese patients and patients with chronic kidney disease have a low adiponectin level. Leptin is the one that sends signals, that is produced by the fat cells, and it sends out the message to the hypothalamus that there is enough body fat storage, and so we should stop eating, or the person should stop eating. But there could be a leptin resistance that can creep in, and the patient or the person can keep on eating. Coming to chronic kidney disease, the obesity is also associated with insulin resistance, renin-angiotensin aldosterone activity that is increased sympathetic nervous system activity, and then low adiponectin, as we talked about, and there could be leptin resistance. All of this usually results in what is the hallmark of chronic kidney disease related to obesity, which is hyperfiltration and increased intraglomerular pressure in the early stages. And it could be associated with obstructive sleep apnea that can compound the hypertension and the metabolic syndrome in these patients with chronic kidney disease. So one thing, it becomes a vicious cycle. The renal phenotypes of obesity-related chronic kidney disease are on the left-hand side, which is the proteinuria. And in prolonged obesity and established cases, they can lead to what is called as focal segmental glomerulosclerosis, or secondary form of FSGS. So this is not something immune mediated. This is more to do with the hyperfiltration injury that is persistent and can then lead on to chronic kidney disease and end-stage kidney disease. The GFR, the glomerular filtration rate, can be increased initially, and then as the obesity and the chronic kidney disease progress, the GFR keeps going down to the stage of end-stage kidney disease. And there is an association with, increased association with kidney stones, with renal cell carcinoma. And this is compounded by the associated or the comorbidities that go with obesity, like the cardiovascular disease, peripheral vascular disease, the difficulty to exercise, the difficulty to stick to a diet, the associated obstructive sleep apnea, diabetes, hypertension, all of these compound the renal injury that is mediated by obesity. I won't go into much of the statistics. There are a lot of studies that have shown that obesity is a risk factor for developing chronic kidney disease in the first place, and that it is also a risk factor for the progression. Once the patient has chronic kidney disease, that those who are obese progress more rapidly. But I'll take you to this paradox called obesity paradox in patients who are on dialysis. Once the chronic kidney disease progresses to the stage of requiring dialysis, end-stage kidney disease requiring dialysis, which is usually less than 10 mils per minute of GFR, that's when, or when the patient is on dialysis, you see that there is an inverse association with the body mass index. Those who are obese actually fare better. They show a better survival. This is the general population that shows the worsening survival with increasing BMI, as you would expect. But if you look at the patients on dialysis, and these are not hundreds or thousands of patients, these are tens of thousands of patients analyzed again and again in the USRDS, which is a US renal data system. And again it has come up with this same association, which is that the higher the BMI, patients on dialysis do better. Various theories have been proposed, and whether it is just an association, whether it is some fallacy of these confounders, etc. But this analysis of marginal structural model, I'm not a statistician nor an epidemiologist, but what I learned from the literature is that this is a way of looking at the robustness of the data, that there are no confounders that are contributing to this association, that it implies a causality of increased BMI and increased survival in patients on dialysis. So this study that was published in the Nephrology Dialysis Transplantation in 2016 looked over 5 years of data from 580 dialysis units and looked at data pertaining to 123,000 patients, so a large body of data there. And what they found was similar to what you find at baseline, similar to what you find on a time-dependent analysis, the MSM or the marginal structural model again confirms that higher the BMI, better is the survival. The mortality is less in these patients. So there is something that gives some protection to these people who are obese when they are on dialysis. And what could be those factors? It could be that there are two competing risk factors. The short-term risk factor of protein energy malnutrition that is so prevalent in patients on dialysis that it kills them quicker than the longer-term bad effects of obesity, if you know what I mean. Patients who are on dialysis typically have 15 to 20% annual mortality. So the mortality is huge, and most of it is driven by infection, cardiovascular disease, or by malnutrition and inflammation that is called as a malnutrition inflammation MIA syndrome. So it may be that there is a competing risk factor there, that obesity is giving a bit of buffer there, so to speak, from this malnutrition related mortality in these patients. And adipose tissue has increased number of tumor necrosis factor alpha, TNF alpha receptors. So they can mop up the inflammatory signals and probably lead to a better survival in these patients. And given the same cardiac index, same ejection fraction, obese people tend to have a higher blood pressure. And maybe that is an advantage in patients who are on hemodialysis, that they don't drop their blood pressure, they don't have the myocardial stunning that frequently happens in patients who have hypotensive episodes on dialysis. So all of this could contribute to a better survival on dialysis. Most of these reports coming from the US are in hemodialysis patients, because predominantly patients in the US are on hemodialysis. When an Australian study looked at patients on peritoneal dialysis, they found the correlation in Maori New Zealanders, but not in the other Australian population. So there could be a bit of a discrepancy in those who are on peritoneal dialysis. But by and large, this is a very well accepted fact that patients who are obese tend to do better on dialysis. Now, just as an illustrative case, this is a lady who has been on dialysis secondary to end-stage kidney disease due to diabetes. When the arteriovenous fistula was created 5 years ago, unfortunately she developed skin infection that led to MSSA, bacteremia, and infective endocarditis of the aortic valve. She had that replaced. Now she's on hemodialysis. I'm sorry, the height and weight and the BMI haven't come up there, which I filled up later. The BMI is 37. And she has been trying to lose weight very sincerely, very passionately by attending the gym, going to the pool, sticking to the diet, low carb diet, etc., and went on injection liraglutide for the last 1 year. But the BMI hasn't changed. It is still around 37. And when we looked at the people who were waiting for their weight to drop to be listed for a transplant, we found at least 30 of them. There might be more that we haven't even, that our colleagues haven't even referred to us, because they can see that the patient is much overweight or obese and they don't have a chance of getting a transplant. So amongst the ones that have been referred, we could see there were 30 as opposed to those around 50 or 47 that are on the active transplant wait list. So one of the barriers to transplantation is the high BMI, apart from the immunologic barriers and other non-immunologic barriers. And why is there a concern? While we are happy or not too fussed about somebody who is on long-term dialysis being obese, why are we worried when it comes to transplantation? We can all intuitively appreciate, and our surgical colleagues do it more often than us, that there is a delayed wound healing. There are higher rates of wound infection, that there is prolonged hospitalization. All these are understandable. And we can also understand that the incidence of post-transplant diabetes or new onset diabetes after transplantation is much higher in the obese patients. But what comes as a surprise is that the obese patients who get a transplant also end up with delayed graft function, that there is an increase in the mortality. For our junior colleagues who may not know about Thomas Tarsal, he is the father of modern transplantation, and his team in Pittsburgh were instrumental in establishing renal transplantation, liver transplantation, introducing triple immunosuppression, so many other things. So he's the doyen. He's a real father of modern transplantation. Their team in 1990 looked at the obese versus the non-obese. They were the first to draw attention to the transplant community that obese patients may not do as well as the non-obese counterparts. If you look at the patient survival in the non-obese patients was inferior to the obese patients was inferior to the non-obese patients, and the graft survival was inferior to the non-obese patients. These were very early studies in the 90s. And looking at a more recent data set from the US renal data system between 88 to 97, 10 years worth of data that was published in 2002, they looked at 51,000 patients. And they could demonstrate that there was an increased risk of graft loss, up to 40% increase in the risk of graft loss in patients who had severely elevated BMI. And they also demonstrated a worsening risk for mortality in patients who were obese after transplantation. A more recent data that was analyzed as a meta-analysis in 2016 demonstrated again the same, 2015 again came up with the same conclusion, that patients with increased BMI, and they took a cutoff of 30 or above or 30 or below. And they said those who had a BMI of above 30 had an increased perioperative mortality, delayed graft function, and new onset diabetes. This was the 30 studies that they looked at, including 15,000 patients, and delayed graft function was worse in the high BMI group, and it favored the BMI less than 30. Graft survival at 1, 2, and 3 years was better in patients who had low BMI. Wound infection and incisional hernia, as all of us can intuitively think, the BMI less than 30 did better. And of course, again, new onset diabetes, post-transplant diabetes was at least 2 times there was more risk in patients who were obese. And even patient survival, even at 1 year, 2 years, and 3 years, that effect remained, that there was worse outcomes in patients who were obese and received a transplant. So we know that patients, although they seem to have, or they have a survival advantage on dialysis, but if you look at providing them the ideal solution, which is the transplant, they tend to do bad, they tend to do worse. And therefore, people have looked at how we can correct this. Are there any medical therapies? One study that came up in New England Journal of Medicine in 2017, and these were not end-stage kidney disease. They were patients with mild CKD. As you can see, the estimated GFR was around 65 to 75 mils per minute. So they were in the early stages of CKD. Large number of patients, 9,000 patients, they were on liraglutide for the control of diabetes. And the eGFR decline over this period, or 36 months period, was very marginal, or the difference was very marginal. The decline was around 7.5 mils, and this was with liraglutide, and this was with the placebo. A very small difference. And what drove the difference was mainly the incidence in the albuminuria, or the progression of the albuminuria that worsened without liraglutide, whereas liraglutide gave a better control of the urinary protein or albumin excretion. Does it work? Any intense medical intervention like exercise, nutrition, behavioral therapy, and fat absorption inhibitor, lipase inhibitor like orlistat, does that make a difference? Just going to the summary of this study that was reported from London, you can see that amongst those who agreed to go on this study, few of them dropped off because they couldn't keep up with the rigor of this trial of physical exercise, the diet, and all of that. These were either end-stage kidney disease or they were chronic kidney disease patients. 35 of them were accepted for the transplant wait list when they reached the target body mass index, whereas only 6% that said they will do it by themselves, self-directed goals, they could achieve only 6%. So that is under intense study conditions. What happens in real life? And this is the data from the United Network for Organ Sharing, or the UNOS data from the United States. And these patients, around 1,600 patients, they were otherwise fit for transplant waitlisting. The only thing that was a barrier was the weight. So these were kept as listed temporarily inactive, status 7. That means they are obese, and until they get their weight down, they will not be listed. Otherwise, they are suitable. And what happened? Over a period of 5 years or 6 years, you see that still about 60% remained inactive, and only about 40% or 42% were activated. And there are these competing events that are happening in patients on dialysis. The reason we think time is the essence in our patients is because the longer they are on dialysis, the longer is their dialysis vintage, their survival, and even after transplantation is poorer. And many of them died, and many of them were deleted. And so you can see that more than 60% of patients who know that by losing weight they can be activated on transplant wait list cannot achieve this in a day-to-day life or in a real life situation. And that leaves us with some surgical options. And how does the bariatric surgery do in helping these patients who would benefit from a transplant? Bariatric surgery could be divided into two major groups: those which are restrictive, restrict the capacity of the stomach, and those which are malabsorptive, which give rise to malabsorption. The ones we will talk about, or we will concentrate about the gastric band. We won't talk about the gastric band much because it's nowadays not much practiced. The one that is commonly practiced is the sleeve gastrectomy. Roux-en-Y is a combination of both a restrictive and a malabsorptive procedure. But we'll talk about the sleeve gastrectomy because we have the maximum data with this procedure. I'll skip a couple of slides just in the interest of time. So this is how the sleeve gastrectomy diagrammatically looks like. There's a vertical part of the stomach, majority of the fundus of the stomach. If you remember, the part that produces ghrelin is also taken out. And it becomes like more like a tubular structure, and it gives rise to easy satiety. Initially, sleeve gastrectomy was thought to be the step 1 procedure for a more complex procedure in obese patients. But when they looked at data, they realized that this by itself was good enough, and it was more simple procedure, laparoscopic sleeve gastrectomy, and requires shorter operative time. The only disadvantage is that because it is done, once done, you cannot reverse it. If the patient loses too much weight in a small number of patients, that might happen, and you cannot reverse the procedure because it's done and dusted. We'll look at two sets of data. The first one is the annual bariatric surgery data looking at chronic kidney disease patients from the US. They seem to be doing hundreds of thousands of patients bariatric surgery every year. I'll go through the data and come back to the other slides. So if you see, that year, that was reported last year, so the patients, there were 323,000 patients that underwent bariatric surgery in the US. And out of that, a minuscule of them had chronic kidney disease, about 1,600 patients. And there were still fewer patients who had end-stage kidney disease who were on dialysis, less than 1,000. And you can see that, as you can expect, the mortality with patients as they developed chronic kidney disease, end-stage kidney disease, it increased. The same thing with the risk for reoperation, intervention, readmission, acute kidney injury. All of this increased as the severity of chronic kidney disease became higher. But look at it from this point of view, that you can see here that no chronic kidney disease, end-stage kidney disease. You see that there is an incremental higher risk there. But if you compare it with some other surgery, elective surgery that patients with end-stage kidney disease undergo, like say gallbladder removal or any other surgery, elective surgery, the mortality or any of these morbidity rates were not higher. That means it carries the same morbidity mortality risk as having any other elective procedure. This doesn't add to the risk. And that brings us to this paper that has been just published in the American Journal of Transplantation. This is the largest single center trial that was done between 2011 to 2018. And out of 499 patients that were referred for bariatric surgery for transplant waitlisting, 198 patients with end-stage kidney disease, and there were some patients with chronic kidney disease, not yet in end-stage kidney disease, 45 of them. And they were subjected to bariatric surgery. And they achieved good reduction in body mass index. About 72% achieved a body mass index of less than 40. We are talking about the US population, and 40 is an acceptable BMI for that center's listing, whereas we struggle with 35 here. So it again depends on the expertise and etc. It prompted the editors to put it on the cover page that bariatric surgery has come of age and should be considered in patients who are undergoing transplant or who are to be transplant waitlisted. So the 499 patients that were referred, and out of them 198 patients were with end-stage kidney disease that underwent sleeve gastrectomy, 45 patients with chronic kidney disease underwent sleeve gastrectomy, 256 patients did not undergo sleeve gastrectomy. I cannot find out why they did not undergo, whether it was the patient's choice or the surgeons thought it was too risky or what it was. But we have data about some of them that chose to be on medical therapy and were used as comparators. So these patients, about 40% of them were waitlisted and received a kidney transplant. A majority of those waitlisted received a kidney transplant. And majority of those who were not yet waitlisted, they were in the process. So more than 90% of them were progressing towards being waitlisted, which is very encouraging. Again, you can see that the competing risk is always about mortality in our patients on dialysis. So we have to get there in time, act to save our patients. So this is demographics of the patients, and male and female. Females were a bit higher in number, about 141 patients compared to 102 patients that underwent the sleeve gastrectomy. And they had the usual comorbidities, like hypertension was most prevalent or almost universally, 85%. You see the diabetes in about 60%, obstructive sleep apnea in about 50%, coronary artery disease in 11%, etc. So they had the usual mix of comorbidities that most of our patients on dialysis carry. Good thing about the surgery, sleeve gastrectomy, that I can see here, is that the surgery took on an average 2 hours. Not a prolonged surgery that you'd be worried about, concerned about. The blood loss was significant in some patients, but not always. And in those, we need to be wary, because our patients who get blood transfusions can get sensitized, and we need to work around cell savers, etc. But the ICU admissions were minimal, and complications were very minimal. And what happened after surgery? The weight decreased from a 129 kilo mean to 104 kilo, and the BMI decreased from 44 to about 36 on a mean. The need for the antihypertensive medications, anti-diabetic medications, they all were reduced. So they got a better control of the hypertension, better control of diabetes, etc. And there's something interesting in patients who had early stage chronic kidney disease compared to those who are on dialysis. That we talked about the early hyperfiltration injury, and that seemed to be abrogated in patients who had early stage chronic kidney disease, CKD1 and 2. The numbers are small, but you can see when you apply the Cockcroft-Gault formula, there was an improvement. A decrease in the creatinine clearance in that population is good because you are preventing the hyperfiltration injury, and that's what happened in that population. Whereas in stage 3A and 3B, the GFR improved, so the renal function got better, not by the hyperfiltration, but otherwise it got better. So the summary of that study was that many of the patients went on to the transplant wait list and received transplant or being worked up for transplant. There was no mortality at 90 days, and there was a decrease in the number of antihypertensives, number of anti-diabetic medications, and even reduced the incidence of diabetes. So looking at the registry data from the bariatric surgery registry from the US and this single center study over 5 years in the US, we can conclude that sleeve gastrectomy, especially amongst the bariatric surgical procedures, it safely improves the transplant candidacy in patients who are on dialysis. It provides significant and sustainable effects on weight loss and reduces medical comorbidities like hypertension, diabetes, and improves renal function in early stage 3 patients. So we are coming to the end of the talk, and what we have discussed until now is that obesity is a risk factor for the development of chronic kidney disease and for the progression of chronic kidney disease. We have also acknowledged that there is a paradox that patients on dialysis and especially on hemodialysis seem to do better, the obese patients compared to the non-obese patients. However, when they progress to transplantation, the survival of obese patients is worse due to various factors that we looked at. And bariatric surgery offers a pragmatic hope of benefit in these patients. And the type of bariatric surgery that has been most studied in these patients is sleeve gastrectomy, and we have got reasonable amount of data now to advocate for this procedure in our patients. And wanted to inform you all that we, as the transplant unit, renal transplant unit at Fiona Stanley Hospital, have now embarked upon bariatric surgery for those 30 patients that we talked about who are waiting for the transplant wait listing, to start them subjecting, of course, subject to their approval and the surgeon's opinion, etc. The process has already started. The first patient might receive a bariatric sleeve surgery, which is a sleeve gastrectomy laparoscopically, in the next few weeks. And we plan to do at least 6 surgeries this year and then review the situation as to how things are going. I think it may not be ideal, but it is the most practical, most pragmatic approach to tackling obesity, especially in a patient population who are always at risk of death due to various competing risk factors. And there I stop, and I'm happy for any questions.
Thank you very much.